This video will discuss performing a lumbar puncture at Boston Medical Center. As with other bedside procedures, an LP can be done for both diagnostic or therapeutic purposes. Diagnostically, it is most commonly done to evaluate for an infection, and less commonly for occult subarachnoid hemorrhage or other inflammatory diseases of the CNS. Therapeutically, serial LPs can be done to decrease the CNS pressure in diseases like pseudotumor cerebri or cryptococcal meningitis, or provide a vehicle for intraspinal delivery of medications or chemotherapy. There are some relative contraindications to lumbar puncture. Probably the most feared complication from LP is herniation from decompression of the spinal column in patients with an elevated ICP due to a space-occupying lesion. This is an exceedingly rare complication, even in cases when lumbar punctures are done with increased intracranial pressures. While the appropriate coagulation profile to safely perform a lumbar puncture is not known, it is generally accepted that INRs greater than 1.4 or platelets less than 50,000 can be associated with an increased risk of bleeding. Reasonable data does exist that aspirin use alone does not pose an increased risk of bleeding, but it is unclear about other antiplatelet drugs. Anticoagulation immediately before or after the procedure is associated with increased risks of bleeding, and therefore it is recommended clearly not to perform the procedure in a patient on Coumadin and to stop heparin at least 4 hours before and wait several hours afterwards to restart. This New England Journal article looked at patients who might be at risk for increased complications after an LP and who need a CT scan before the procedure. Any patient older than 60 who is immunocompromised, has a history of prior CNS disease, has had a seizure within 1 week, or an abnormal neurologic exam would be more likely to have an abnormal head CT, which should be done before an LP. However, even in these patients, most were still safely able to undergo the procedure without complications. The consent form at Boston Medical Center is a blank form that relies on the operator to insert the name of the procedure, the details, and the associated risks. All too often, it is common for consent forms just to be listed with the medical name of the procedure alone, like thoracentesis. This is an inadequate consent and would not appropriately document the discussion of the risk-benefits of such a procedure, even if it did in fact happen. After consent, a timeout is then performed. This is a joint commission requirement during which the operator and another individual, usually the nurse caring for the patient, performs a checklist to confirm the correct patient, procedure, the correct side, and other necessary items. At BMC, all operators must then initial the green timeout sticker, which is placed on the reverse side of the consent form. After consent and timeout, equipment can then be gathered. All the equipment pictured here is required, including a mask, sterile gown, gloves, sterile table cover, extra chlorhexidine swabs, and a Cardinal 21 gauge LP kit. While chlorhexidine is a superior antiseptic, its use right before an LP is controversial because chlorhexidine, when it comes in contact with the spinal column, has been associated with arachnoid inflammation. One approach is to provide an initial prep with chlorhexidine, then use the betadine swabs in the kit immediately before the spinal needle is introduced. The kit itself includes most of the necessary items for an LP, including the antiseptic for the final prep, patient drape, small bed drape, 2 anesthesia needles, and a small vial of lidocaine, gauze, and the LP needle. It is common that patients need additional lidocaine to what is in the kit, which needs to be ordered in SCM and brought separately. An LP can be done both sitting up or in the lateral recumbent position, which is the best position to measure an accurate opening pressure and decreases the chances of a post-LP headache. In this position, with the patient bent into a near fetal position, the iliac crest intersects at the L4 vertebrae. Just above this, at the L3-L4, or just below this, at the L4-L5 interspace, is where the spinal needle will be introduced. In an adult, the spinal cord ends at or near L1, and thus entry into the spinal canal occurs distal to this location. The proper angle to introduce the needle is somewhat cephalad in order to run relatively parallel to the downward angled spinous processes. After passing through skin and soft tissue, the spinal needle will traverse the supraspinal ligament, the interspinous ligament, the ligamentum flavum, and finally the dura and arachnoid. You may feel a characteristic pop when the dura is entered. After hand washing, the patient is positioned and the appropriate site is marked. A sterile table is then set up, the patient prepped and draped sterilely with a fenestrated drape over the site and a smaller drape on the bed. The 23 gauge needle is used to make a small wheal just over the inner space. And then a longer needle is used for deeper anesthesia. The spinal needle used at BMC is a 21 gauge needle with an inner stylet. It is introduced, as mentioned, in a slightly cephalad direction said to be in line with the umbilicus. It is also recommended to orientate the bevel of the needle up towards the ceiling, as when it enters the canal, it is more likely to separate the fibers of the cauda equina rather than shear them. As the soft tissue and ligaments are traversed, the inner stylet must be completely removed at each interval to check for CSF flow. If no flow, the stylet is replaced and the needle is advanced. At some point, you will likely hit a bony structure on the vertebrae, either a spinous process or lamina. The needle is then withdrawn slightly, repositioned either cephalad or caudally, and then re-advanced until CSF is seen. The two-piece manometer is set up and attached to the spinal needle, and the meniscus is allowed to equilibrate to get an opening pressure. The CSF is then withdrawn into the 4 clear tubes provided, putting on average between 3 and 4 cc's into each tube. The stylet is then replaced, and the entire needle is taken out with pressure held. Each numbered tube is labeled and sent for the typical CSF test listed here. After lumbar puncture, the patient should be instructed to lie flat for several hours to reduce the chances of a post-procedure headache. The risks of other complications are much lower and listed here. Lastly, using the available template, a procedure note is entered into SCM.